Hello and welcome to One on One. I am Cyril Stober. My guest today is a professor of hematology, oncology and bone marrow transplantation. Well, his experience in the practice of medicine cuts across 3 continents. That's Africa, Europe and North America. And he parades a sterling CV as a medical practitioner. Just a little bit of what he's been. He graduated from ABU Zaria with MBBS, and that was in 1982. He became a consultant pediatrician and fellow of the West African College of Physicians in 1989. And thereafter, on a scholarship, he went for a postgraduate diploma in tropical medicine and hygiene at the University of Liverpool in the UK. He subsequently worked at Christie's Hospital and Holt Radium Institute in Manchester as an oncologist between 1990 and 1994. Thereafter, he moved to the United States of America, where he was a fellow of hematology and oncology at the Medical University of South Carolina. In 2000, he moved to the world-renowned Bone Marrow Transplant Center of Fred Hutchinson Cancer Research Hospital, Seattle in Washington, as transplant fellow and assistant professor. Of course, in 2003, he moved to St. Jude Children's Research Hospital in Memphis, Tennessee, as assistant professor in the division of stem cell transplantation. Now, he rose to the rank of full professor in 2008. I did say that he has a sterling CV, but today he is the executive secretary of the National Health Insurance Scheme, the NHIS, and that's what we'll be talking about on One on One today. Let's welcome Professor Usman Yusuf. Thanks for being with us today.
Thank you, Cyril, for having me here today.
Well, we've had to sit down with you in the past on One on One to talk about the National Health Insurance Scheme and just how that scheme is responding to the health challenges. But let's begin on a general note this time around and ask, how positioned is the NHIS now?
Good. So this is, what is the NHIS? What is the mandate of the NHIS? We look at what the mandate of the NHIS is and look at whether or not we've achieved that mandate and what has been the problem and where we need to go. The mandate of the NHIS essentially is to cover all Nigerians, 170, 180 million of us. What we hear everywhere called universal healthcare coverage. What universal healthcare coverage is essentially, it's a very simple but inspiring concept. What it means is that all 170, 180 million of us must have access to easy, affordable, quality healthcare, regardless of our economic status, and regardless of our employment status, without inflicting financial hardship. The reality, Cyril, is many of us, including you sincerely, they say we are one serious illness away from poverty. One major illness will just wipe away whatever savings we think we have. Agencies like this, the NHIS, are meant to help people. When they get very sick or when they get sick, they don't have to sell their goods, they don't have to sell their assets to be able to access healthcare. So universal healthcare coverage essentially says every person, regardless of his station in life, or whether he's employed or not, should have access to good quality health care without inflicting financial hardship. And also, that health is not only a human right, but an access towards poverty alleviation. Any nation that covers its people is a nation that is rich. And we've seen that in very many countries that are not as rich as others, but are healthier and more productive. So essentially, NHIS, that is what we are supposed to do. But in 12, 13 years, have we achieved that mandate?
Right.
And that's what we'll come to later.
All right, so first we would like to know just how many Nigerians, given this population, our population, how many Nigerians have access to the NHIS, and what's the scope of its coverage?
Yes, so there are a lot of numbers bandied around, but I'll tell you what recommendations of the WHO says to nations, to governments, for them to achieve UHC, because it's all over the world. UHC everywhere. WHO recommends to governments 4 main priorities to strategize. Number 1, governments should try and reduce the out-of-pocket spending for its people. Now, if you go to hospital, it's about 60 to 70% of whatever you charge out of your pocket. Number 2, increase the risk pool. Because the more healthy people you have in the risk, the more we are able to take care of those who truly need it. Number 3, governments should try and make health insurance mandatory. Because currently, as is in Nigeria, it is voluntary. And the few that pay cannot necessarily pay for the large that need it. Number 4, and most importantly, and every government is acutely aware of this, is that government should pay for those who cannot pay for themselves. These are very noble and these are very weighty challenges to governments. That pay for those who cannot pay for themselves. Reduce the out-of-pocket spending for your people. Increase the size of the pool and make insurance mandatory. These are the 4 strategies. Over the years, you're asking me how many Nigerians are covered by the NHIS. So when I came, I asked the same question. I don't lie because I know not how. The honest truth, when I came, there was nobody who could lift his holy scripture and give you an exact number. I want that to sink in. This is sobering truth. In a nation of 180 million Nigerians, with the resources we have, we cannot say the exact number of Nigerians that are covered.
So how then can you plan?
So data, without data, how can you plan? It's a very good question. So what I did when I came from academia, we asked questions. How many Nigerians are covered? How much has gone into the system? How much is the output? Was carrying Ghana must go home to study and find out. Because for me, I have been doing clinical research and bench research. And boom, I'm on this chair now selling insurance. I needed to learn very quick too. So I needed to catch up with things. What I found was not a good thing, not a good side. In spite of all that has gone into the system, Nigerians I paid for, I don't know if there is a number anywhere else that somebody is hiding. It's 1% of Nigerians.
1%?
Exactly. Of Nigerians that are covered.
That's abysmally low, isn't it?
Thank you for saying it. This is true. But that's the truth. And unless, in psychiatry there's this thing we call insight. If you're a crazy person and you have insight that yes, I'm sick, I need help, your prognosis is better than a person who says, no, I'm okay. So this is what I said when I came in. Guys, this is where we are. We must look at ourselves and say this is not acceptable. But it's the truth. So all these numbers we're talking about, 10%, 15%, 16%, that's not what I found. What I found is this. Why are we where we are? And how can we get out of this rut? This is the reality. This is what I found, 1%.
Right. Now, this 1% that we talk about, I believe that it's mostly made up of people who are in the public service, who ordinarily would have no choice because their deductions to the NHIS would be automatic from whatever they earn. But even then, there's still a lot of complaints about who actually has access, where they can go to, who's registered. Let's take it, step by step.
Good. So let me tell you, in spite of all the failings of NHIS, and there are many, and I'm the first person to go and shout that, yes, we have failed as regulators. I will tell you NHIS has the potential to do a lot of good, impact our people positively. Here I was, before I came here, bench research and clinical research, seeing few patients, and now here I'm on this chair in an agency that has the potential to make a difference, an impactful difference in millions of Nigerians. Right? So what are the potentials of Nigeria, of NHIS? Clearly the potentials have not been harnessed. In spite of all of that, I will tell you, since the advent of NHIS, NHIS has increased access to healthcare to our people. NHIS has reduced the cost of healthcare. I will tell you, I was in Ilorin the other day. A private practitioner in Ilorin sought to see me, and he came to my hotel room and said, Ogasa, you will appreciate this because you're a pediatrician. The commonest, the 5 killers of children are, number 1, malaria and its complications, diarrheal diseases, respiratory illnesses, illnesses that can be prevented by immunizations, and malnutrition. So, sir, since the advent of NHIS, in my practice, malaria does not necessarily, common malaria does not necessarily kill the child. What kills children are complications from malaria. Malaria of the brain, cerebral malaria, malaria of the kidney, malaria that gives children diarrhea and vomiting, and severe anemia from malaria. He says, sir, I will tell you this, since NHIS came, I don't see severe malaria anymore in my practice. Therefore, death from malaria in my practice has really gone crashing. And he says, you know why, sir? I say, no. I say, previously, mothers did not have access. But now they do have access. They bring these children early on in the disease, rather than them bring a child limping or convulsing, because they had no choice but to bring him to me. It's gladdening to know NHIS, in spite of all the beatings we are given, this has improved access, increased access, has reduced costs, and most importantly, NHIS covers all our men and women in uniform.
Okay.
So its survival has national security implications. We cover our men and women and their families, these men and women who we owe a debt of gratitude, and their families. The largest HMO in this country is Police HMO.
Right.
So it has done good. We have a lot more to do.
But then you just mentioned it, and it would seem that in the whole concept and the practice of the services of the National Health Insurance Scheme, one recurring thing you hear is the HMOs. What is the position of these HMOs in the scheme? How do they relate with the hospitals who provide the healthcare services, and of course those who benefit from the scheme? Who are the HMOs?
Good. HMOs are health maintenance organizations, and they came from the United States, where I've lived for a long time. When NHIS, and they are supposed to be middlemen. We don't give hospitals money directly. We give money to NHIS, gives money to these companies called HMOs to pay hospitals on behalf of patients and their families. So it is a system that came from the United States into Nigeria.
Is that system working properly? Because you do get complaints that people go to hospitals, they turn back, and usually it is about the HMOs have not made the necessary payments to the hospitals, or sometimes people who are in need of healthcare have to wait. Hospitals have to, contact HMOs. So the question is, who's benefiting from the system? Is it the HMOs? Is it the enrollees, or who?
Good. So there are four major stakeholders in the NHIS. We, the NHIS, as the regulators, the HMOs that we give money to, the hospitals, and then the person we call the enrollee, that is the contributor. Over the years, this enrollee has gotten lost in the shuffle. It's just like in the teaching hospitals, you hear doctors, nurses, pharmacists, everybody struggling to be a chief medical director. Nobody's talking about the patient. So also, in the healthcare financing system I found, everybody, NHIS, HMOs, hospitals, nobody is talking about the enrollees. I said, people, we have a person or group of persons that are paying our salaries that we are supposed to work for. Who are HMOs? There's a lot of blame to go around, but the biggest blame, I look inward. I see all the failings you see in the healthcare financing system is a failure of regulation. We are the regulators, we the NHIS, and the act that set up the NHIS gives us enough powers to regulate. We haven't done that. And we have to own it up and say, we've not been the regulators we needed to be. And I'm the first one going around telling the whole world, yes, there's enough blame to go around. What of HMOs? HMOs, before I came, we used to give them money a quarter ahead to pay hospitals. That's 90 days ahead before services are rendered to give hospitals. But what I found when I addressed committee of CMDs and told them, ladies and gentlemen, I am in the midst of friends, and I can take liberties and tell you guys the truth. The truth is you are not treating our patients well. What they tell me is HMOs are not paying them. So I came back to HMOs, why have you not been paying them? It's amazing. Cyril, we give money to these companies to give hospitals, majority do not pay.
Let me understand this properly. Well, it might not be workable, but people have said, why do you need someone in the middle? Why not deal directly with the hospitals that provide the services? What is the advantage of having someone in the middle? Because you've got to think about the bureaucracy, certainly, about receiving funds, paying funds, delays that might arise, and what if hospitals have to contact HMOs? Somebody needs health care. He doesn't have time to wait around for that to happen. And are the HMOs located within the locality of the hospitals providing these services?
Very good question, Cyril. So when I came, I saw this, I said, this cannot continue, so I had to shake the tree. Looked at ourselves and said, we've not been doing the right thing. And we've admitted it and we're doing better. HMOs, the licenses of many HMOs have expired as far back as 2013, 2014. And we've been giving them money. And I ask questions. Would the central bank deal with any bank that doesn't have a license? Will NNPC give money to petrol stations that do not have licenses? Then why has the NHIS been dealing with HMOs that do not have licenses, giving them people's money, and they're withholding that? So what I've done, I said we're going to re-license all HMOs nationwide, 57 of them. And we started this licensing process in April last year. The first condition I put is all HMOs must present to the NHIS a certificate of non-indebtedness signed by the chief medical directors of each hospital they serve. If an HMO serves 1,000 hospitals, go to those 1,000 hospitals and get me a certificate of non-indebtedness signed by the chief medical director. Said, you don't owe them anything. Now hospitals, chief medical directors of hospitals are calling me and thanking me for empowering them. HMOs are paying. They are paying hundreds of millions and billions of money they kept, they were not paying back. All this money will be paid back because it is people's money that should go to health care of people that they were holding. So this is very important. We are concluding the process, and by the time we finish the process, first week of September, we'll publish in national newspapers HMOs that have qualified to get license. Currently, as we speak, in the process, we've been doing the process. Currently, as we speak, the only HMO that has qualified to have full license is Defense HMO. 53 HMOs. We've been doing this process. Initially, it was only one HMO that qualified, Defense HMO, with all, and we are not making anything new. There are guidelines. This may sound, but I'm thinking, how long is this process? Because you have about 53, and is this process a cumbersome process that probably would take maybe one HMO 3-6 months before they can fully meet the conditions? So how stringent are these conditions? Because I'm wondering if you started April last year, you said. Good. And within April last year and now, I'm expecting perhaps we should have about 40 or so, or 30 or 40. Good. So this reaccreditation process is done every 2 years, relicensing process. All right. So this time around, the first time we did reaccreditation, no HMO passed. So we had to look again, because we put criteria not made up. They're already in the guidelines and the act. So did you have to lower it for them to meet up? So what we did was to look at and see, because we are looking at, we don't want to throw away the baby with the bathwater. There are issues we can close our eyes and say, yeah, we'll take care of this. But what we were not going to close our eyes to is paying debt. All debt to hospitals must be paid. Hospitals must have CAC registration. HMOs must have CSC registration. HMOs must be fully capitalized. HMO must be spread all across 6 geopolitical zones. This is so. We started in April. The first one we came, none of them qualified, and then we looked at it again. Only one qualified Defense HMO for full license. Okay. 56 HMOs then. No, 33 HMOs qualified for provisional. Provisional means you have 3 months to sort out problems. Right. Then 23 at that time did not qualify at all for licensing. We presented this to management, we presented this to council, and then it was agreed with the management and the council. So we will give these 23 HMOs that did not qualify even for provisional, we'll give them 2 weeks remediation. In these 2 weeks, fix problems that are fixable for you to qualify into the provisional. And then after these 2 weeks, 4 were outrightly delisted because they couldn't. Now what we have is 53 HMOs that have provisional licenses. And we have finished the process of the reaccreditation, and we are going to present it again to our council. First week of September, we will tell Nigerians how many HMOs have full accreditation and how many HMOs are delisted, and we'll put it in the newspapers. Okay, 2 things that arise here. While this process was on, what happened to the run of the scheme, and what about the hospitals themselves? No, everything continued as is. Nothing has been disrupted. Because the whole idea is, it's not about me or the council or the management or HMOs. Our priority first and foremost is to our enrollees, to our patients. So services have not been disrupted. We are trying to clean the system. HMOs must continue to pay hospitals regularly and be free of debt.
All right. When we clear the hurdle with the HMOs, we now come to the hospitals that are in direct contact with the
Correct.
enrollees. And there have been quite a number of challenges.
Correct.
You do hear people say they go under the scheme to hospitals. They don't get prompt attention. Sometimes the level of attention they receive is, so poor. Other times we've heard people say, usually only youth corps doctors are assigned to take care of the barest number of patients under the NHIS. And people also say sometimes you get up to the hospital, the minute you mention that you're coming under the NHIS, then the level of attention accorded you decreases. What have we been able to do about that?
Good. So I will tell this to Nigerians that NHIS sustains all tertiary hospitals nationwide. The money NHIS gives to tertiary hospitals to see our patients has been enormous over the years. And I have addressed committees of CMDs and tell them, you have not been treated. Patients in your facilities, our patients in your facilities have not been treated with the respect and dignity they deserve. Wherever I go, I visit hospitals. And my first default, because I'm a pediatrician, I go to children's hospital, a children's ward. And then I go to labor and delivery. But I go around all facilities to see how NHIS fund has been used. There are big problems with hospitals. After we finish the HMOs, what the NHIS plans to do is re-accredit all hospitals nationwide. Why are we doing this? There are hospitals we discovered that never existed, or existed and are out of business, but have continued to be paid capitation. So ghost hospitals over the years. Hospitals in the northeast, or a lot of hospitals in Lagos, even in Abuja, I was in Kano, they say even in Kano there are hospitals that don't exist, they've been receiving capitations. We give HMOs and they... So we're going to re-accredit all hospitals nationwide to see the real from the fake, from the ghost. So we looked at ourselves and said we're not doing right, and we will do right. We're cleaning the HMO system. We're going to re-accredit hospitals. After that, we are going to audit all hospitals nationwide. I know each hospital in this country under the NHI, I know how much has been paid from the beginning till now. But no hospital has been asked to account for the money they've been receiving. NHI's money to hospitals are not meant to cover overhead or buy land cruisers. They are meant to improve infrastructure to allow more of our patients be seen. So we're going to audit hospitals nationwide and ask them to account for the monies they've been receiving annually.
Professor Yusuf, have you heard about this raging controversy relating to drugs? And here I'm talking about branded and generic. And it's alleged, that's why I'm asking if you've heard about it, and if you have, what have you been able to do about it? At times it's been alleged that there are certain facilities that people go to and they'll say to them, well, you're under the NHIS and therefore this is it, this is, well, a generic drug, this is it, but we can tell you that this other thing, this other drug is more effective, more efficacious, but it doesn't fall under your scheme, so you'd have to pay to get this.
Good. So let's allow Nigerians understand what generic medications and branded medications are. If a drug company brings out a new drug, it's invested a lot of money, billions usually, in research and development. In the United States and many countries that these drugs are manufactured, this drug company is given a 10-year moratorium that no other drug company can manufacture that drug until this drug company recoups its research and development fund. After that, then other companies anywhere in the world can have a license to produce the same drug
All right.
This drug is usually generic drug, contains the same components. So when I go to a pharmacy in my neighborhood pharmacy, and they say this is Ampiclox, branded, 10,000, or there's a cheaper one, 5,000. I'm a doctor, I pull it up, I see. The 10,000 one is branded, contains the same thing as the 1,001 that is generic. Right? And I buy the 1,001. The onus is on us, we the NHIS, the hospitals, and the HMOs, to tell Nigerians, to educate Nigerians, the generic drugs are not inferior.
All right.
They are not. They are cheaper, contain the same components, and just as effective. So when you go to a pharmacy, don't buy branded, buy generic.
Okay, because a lot of people would say, look, are these substandard?
No, they're not.
Right. But then, still within the hospitals and the care services they provide to enrollees, again, we must find out what are those things that are covered by the NHIS. Because you do find a lot of people going with illnesses to hospitals, and then they find out that, look, this, what you have is not covered by the NHIS, and of course you know what I'm talking about here. So let's start by knowing what are those ailments.
You will be amazed, Cyril, to know that the NHIS, the package in the NHIS is very robust. This is what we find. Many hospitals, they tell patients this is not covered in the NHIS, which is not true. That is why in major hospitals in Abuja, what I have done is to deploy desk officers, NHIS desk officers. They are there as advocates for patients, and they are there as ambassadors of the NHIS. When patients go to any billing area and they say this is not covered by the NHIS, they come back to that desk officer. That desk officer goes and fights for them. Many hospitals, they say this is not covered by the NHIS. Is not true. What we plan to do, and we are distributing to all hospitals and enrollees and points in the hospitals where patients will pick up and see what is covered, what is not covered. A lot more is covered than hospitals are telling you it isn't. They charge patients twice. That is where the presence of our desk officers in major hospitals will go a long way in reassuring patients and telling them they have somebody who is going to fight for them.
This challenge, has it got to do with the kind of healthcare system we run? Or is it something else? Because you do find situations where people go to hospital and they just want the best. But there are times some would go in and you just get to know, well, things like malaria and all that, fine. But if you begin to lay a complaint of something different, sometimes you've had healthcare professionals advise and say, look, you need to see a consultant, not, a GP. And if you're going to see a consultant, of course, it's no longer a matter for the NHIS. And that's what happens. Many patients are told that in hospitals.
No, and it's very wrong. It truly is very wrong. And it's up to us to continue to educate patients. General practitioners anywhere in the world, they should be the first gatekeepers. It's not everybody who should go to a cardiologist or a neurosurgeon. A general practitioner sees a patient, triages and says, I can take care of this, or I need to send the patient to a specialist.
Right.
There is no specialist that an NHIS patient cannot see. If anybody tells you, oh, the consultant is not covered by the NHIS, he is not telling the truth. I have had to go to hospitals in Abuja. When patients call me, I come to my office. I see on the desk, there's a complaint by a mother. The other day I remembered. A mother whose child was admitted with sickle cell anemia. The HMOs did not refer her. And I had the complaint. I drove there, I met the mother. And I went to the HMO's office. We are talking now as parents, not ES or HMO. You have a child, sickle cell patient, admitted in severe pain, cannot reach you. You are not giving the patient a code to see another doctor. No reason in this world not to. NHIS covers that. NHIS covers a lot more than hospitals are saying. And we will continue to educate our enrollees, and will continue to talk to our hospitals to do the right thing.
It would seem that there's need for an aggressive enlightenment of the provisions
Absolutely.
of the NHIS, and even as the public sector is, provides the largest number of enrollees at the moment, it would seem that there's still a lot that is shrouded in, I don't want to call it mystery.
No, it's the failing is ours, and I agree, all of us, not only NHIS, hospitals and HMOs, educate our people as to what is their entitlement. This is very important. Many HMOs do not want to give a code for the patient to see a specialist because it means they're going to spend more. This is not the ideals of the NHIS. We're here to serve our people.
Now, in terms of location, there could be challenges really, and we've seen that happen. At what point should enrollees be? You'd find cases where people in registering, they're told, no, you can't register with this health facility because they already have too many. You've got to go somewhere. Now, distances. Sometimes people are not close to government facilities, and therefore they have to travel long distances to get to health centers, when, of course, there are other health centers within their vicinity. How can this be addressed?
Right, and the misconception is NHIS patient has to go to a government hospital. It's not true. NHIS patient can go to any private practice in this country, and they will be paid for. Private practitioners in this Abuja that see a lot of patients, of our patients. Every patient now in the NHIS is who you ask, where do you want to choose? Say, National Hospital, National Hospital. You shouldn't go to National Hospital for malaria.
But why do you think Nigerians do that? They want to go to a tertiary institution.
Right,
Why do they do that?
And that's not the purpose of tertiary hospital. Tertiary hospitals are not there to see these common ailments. They are meant to see very serious. But it's people, Nigerian people, and it's going to take a while.
Could it be because of obvious failings at the primary health level? That's why people prefer tertiary institutions?
Not necessarily. To be honest, where I live, I have better contact with the doctor there locally, freer access than National Hospital, because the size of the National Hospital and the people that converge there, access is a lot more difficult than the neighborhood small hospital. So, in the UK, you just don't rush and go and see a specialist. You have a private practitioner. In the United States, same, you choose your private practitioner close to you, neighborhood private practitioner. National Hospital or any of these big teaching hospitals cannot absorb all the primary health care cases, and they will be waste of their time. They should be dealing with serious tertiary issues, not the malaria, not the diarrhea. Neighborhood hospitals can take care of this. So it is people having confidence in their neighborhood doctors, and we are educating them. We are talking to the doctors, because as a doctor, what makes you come back to me is the way I treat you, not the beauty of the place. If I treat you well, you will come back regardless of the place. So it is our responsibilities as physicians to treat our patients well. If a patient goes to a hospital and the nurse is yelling at him or her, why would he or him come back? They won't come back. So how we treat our patients is truly, truly fundamental, and we must treat our patients with the respect and dignity they deserve. And patients will come to he or she that treat patients well, regardless of the ambience of the place.
All right. We agreed that mostly the public sector. What are the plans? Because at the inception of the NHIS, and of course, if you're going to, extend services to a larger population, then definitely the private sector. There are groups that are currently not captured in this scheme. The private sector, very low. And what about the case of retirees?
Good. So predominantly now the NHIS covers the formal sector. And this is a very small percentage of Nigerians.
Right.
The largest percentage is informal sector. Not only in the federal government, but the states. NHIS in Abuja or federal government cannot achieve universal healthcare coverage without involving the states. Period. This is where our people are. That is why what is the NHIS been doing? NHIS has been partnering and working with state. And because why? Because health is on the concurrent list. The federal government cannot go to Katsina State or Kano or Abia and say, you must do this on health. Each state government must do theirs. NHIS has been working with state governments and their legislators for them to create agencies like the NHIS in the states for them to cover their people. And this brings us now to the Basic Healthcare Provision Fund and the National Health Act. So unless we cover the informal sector, we will never go anywhere. Unless the NHIS partners with the states, we'll never be able to reach universal healthcare coverage. What the federal government has done, in 2014, there is the National Health Act that was signed into law. The act clearly says 1% of the nation's consolidated revenue should be dedicated to health. Remember we said health is on the concurrent list? So this is federal government's way of going through the back door and helping the states. The act clearly says and stipulates how this money will be used to the implementing agencies. What are the agencies? First of all, our parent ministry, Federal Ministry of Health. The act says 5% of that money should go to Federal Ministry of Health. For what? For medical emergencies. Remember recently we had Ebola, we had Lassa, we had meningitis, and we have road traffic accidents all over. The Federal Ministry of Health will use this money for that. The next 45% goes to National Primary Healthcare Development Agency. What is National Healthcare Development Agency supposed to do with this money? They deal with primary healthcare clinics all across this country. They're designated, and the whole idea is to have one functional primary healthcare clinic per ward. So National Primary Healthcare Development Agency identifies these primary healthcare clinics. Remember, they are in our villages, they are in our localities, not in the big cities. And they are supposed to use this 45% of their money to rehabilitate these clinics, buy drugs, buy equipment, and help in capacity building of staff of those primary healthcare clinics. What of the NHIS? The component of the NHIS, the Act clearly says if people in the villages go to these primary healthcare clinics and they get billed, the NHIS should be the one to pay. It's never happened in this country. We are truly very, very excited. This is going to be a dawn of a new beginning in healthcare. This is going to be the first time you will start seeing the needle of coverage in the informal sector rising.
So that means the small storekeeper right there down the road, or the man who operates the telephone recharge card booth, the kiosk, or perhaps the vulcanizer down by the street corner should and will eventually have access to the coverage of the NHIS.
Absolutely, and he still does, if he can contribute a little, right? We have a program in the NHIS called VC-SHIP, Vital Contributors Social Health Insurance Program. How much is it to cover? It is 15,000 per annum, which comes down to less than 15 naira a day. For that amount, a patient can access healthcare as I would.
All right.
And we have seen that. Pregnant women go to hospitals, get cesarean section, and NHIS gets billed up over 100,000 and NHIS pays.
All right. Which also brings us to this other vulnerable group, the senior citizens, who have given their all in all. And, well, people are living longer, rightly. And so what happens when they have now become senior citizens and they're only on a stipend as pensioners?
It's a very good question you raised, because people give the best part of their life serving the nation. And when they exit, that is when the contribution ceases.
And perhaps that's when they now face with many more health challenges.
That's when we all, absolutely. As we age, health challenges come. That is when we need the NHIS more. But they have exited and they are not contributing. Mm-hmm. That is why we have been talking to Labour. At the beginning of NHIS, the federal government was supposed to contribute 10%, and it's still doing that. 10% of people's workers' salary into the pool. And each worker is supposed to contribute 5% from his salary. Labour kicked against it. So, since the beginning till now, it is the federal government in the formal sector that has been paying 10% of workers' salary. Workers are not contributing. We've been talking to Labour. This is a great opportunity, especially for young people. If you are able to contribute the 5%, you will enjoy NHIS even after you exit. NHIS as an agency is one of the very few organizations that we are contributing the 5% into the pool. And when our workers exit, they will continue to enjoy health care.
Well, you say for those who are still within the formal sector now can start doing that. That's in addition to what the contributions that are made on their behalf?
No, the federal government is making on their behalf.
Right.
Not out of their paycheck.
But in addition to that.
Right. If you put, because the initial calculation and the initial actuarial is 10%. If you earn 1,000 naira, federal government, without touching your salary, federal government will pay 10% of that money into the bill. And you are supposed to, out of your 1,000, to pay 5.
Right.
But we've not been doing that. So, the reality, and I tell people all over the country, there's a limit to what government can do. There is nowhere in the world that government pays 100% for health care. I was in the UK. We were taxed from our salary. In the United States, it's the same. If you can't afford health care, then you are in trouble. But in Nigeria, I have seen, I was one of the greatest critics of government outside government. Now I'm in government, and I have seen what this government is doing in health as regards NHIS. And I can speak on NHIS because that's why I'm here. And I can see what government, federal government, has been putting in on behalf of its workers. And what this government, President Muhammad Buhari, has had the courage, the political courage to sign in this budget, the 1%, the full 1% into this fund. Everybody is excited, including our development partners. So we're doing more in health than previously.
In other words, for now, the senior citizens are on their own.
No. Okay, so VC-ship, and I will tell you, there was a group of ambassadors, former ambassadors. So VC-ship, Vital Contributor Social Health Insurance Program, you pay 15,000 Cyril annually. One payment, it will cover you even if you go to hospital and you get charged ₦1 million.
So that
NHIS will pay. Okay. So this is what we are selling to retirees.
Right.
And coming to that, 2 weeks ago, there is this association of former ambassadors. I mean, these are men and women that have represented this country in far-flung places of this earth. And we have brought them in and selling this product to them. And I was honored to go to the Federal Ministry of External Affairs to meet these distinguished men and women and be able to serve them like they have served this nation. So yes, any retiree, Cyril, including you and I, can buy VC-ship, which is 15,000 annually, which comes down to 40-something naira daily, and enjoy the same health access as I would.
And so this registration they can do individually or in groups?
Individually and family in any of our offices nationwide.
Go to the NHIS
yes,
office.
Go to the NHIS office. We have 36 offices all across the country, and we have one zonal office in each of the zonal, each of the 6 zonal headquarters. So yes, you can go in there and ask to be registered on VC SHIP. That is where the future is. And we have gone to big churches and big mosques telling people, because essentially insurance is about the healthy taking care of the sick, the strong taking care of the weak, and he who has taking care, subsidizing for he who doesn't. All over the world, even in the most capitalist countries in the world. You that are working, you get taxed heavily to subsidize for those who do not have. So yes, Cyril, you can pay for many more people, I can pay for many more people to help those who cannot pay for themselves.
What do you see the NHIS in the next few years, the biggest moves that you have to take in order to increase 1%? How do you get up to 50%? Let's not be too ambitious yet in the next few years.
Okay, good. Look at this basic healthcare provision fund. What the federal government has put into this government has put into this 55 billion. It's never happened. To cover our people all across 6 geopolitical zones. This, in my opinion, will be a great booster to informal sector. You will see, and it's not only the rich or the poor or people living in urban areas. We are talking vulnerables among us, pregnant women, children under 5, the aged and the poor, all across 6 geopolitical zone. This is for us. It's never happened. We're very excited. And this fund is not only the federal government that puts in there, the Act says any development agents can put in there. And we have so far had contributions from the Gates Foundation, from the Global Fund into this. For us, the NHIS, we want to be able to say,
okay,
how many more Nigerians have we covered next year?
Professor Yusuf, we're just about rounding off now because time is up. But, you know, before we let you go, there's this thing that, we have to put this across to you. Administering healthcare in all its ramifications, it's not exactly easy, is it?
Is it?
And you have also been in the eye of the storm.
Absolutely.
And some time ago you said you've learned a lot of lessons. What are those lessons? What are the takeaways that you have learned in your, could I call it your first time around, and now the second coming. The second coming, right. What are the takeaways?
So for Nigerians that do not know, I was on this chair only for 10 months, and I was suspended for 7 months, and I'm back now for 6 months.
Right.
If you do not go through turbulence in your life, you learn nothing. Nothing. Right? It's not the work itself, but how to deal with people, how to deal with. In Nigeria, going from A to B, even if it's a straight line, you have to go through roundabout and do this. I'm used to get there. I have an order to do this, let's do it. I see an injustice, let's clean it up. There are a lot of things we have seen, and we're doing differently. It's more how it's done than it must be done. We are in this place to make a difference. We remain focused to do the right thing. All these distractions are nothing but distractions. And you will hear me and see me in the news. It's all for the good. What I have learned is do this with, I used to take it seriously. So the other day my wife told me, since you were reinstated in February, you've stolen 65 billion. Or you stole 10 billion, 20 billion, 60 billion. Previously I would get really angry. Now it's, I take it with a sense of humor.
All right.
But not forgetting why I'm here. Remain focused and do the right thing.
All right, Professor Usman Yusuf, Executive Secretary of the National Health Insurance Scheme, NHIS. It's been interesting as usual talking to you. And there's still so much to talk about, and we hope you'll come again, because very soon we'll be asking you to come around again, and let's talk more about the NHIS and the way forward.
Thank you very much for having me, Cyril.
All right, then.
Thank you.
Okay. And that concludes our program today. We thank you for watching. Next week, we'll reach you again on One. I'm Cyril Stober. Bye for now.